A lot of other disease sites, they have some targeted therapies, they have some immunotherapies. In lung cancer, we have it all. We have chemo, we have IO, we have targeted therapies, we have bispecific T-cell engagers now. We have orals, IVs. I think it's just so important now that, particularly for lung cancer, you have to be well-versed on really all of these.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking again with Beth Sandy, thoracic medical oncology nurse practitioner at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia, about treatment for lung cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks for joining us again today, Beth.
Yeah, thanks for having me, Jaime.
So you joined us on a previous episode, and in that episode, we talked about lung cancer screening. So today you're back and we're going to talk about another part of the cancer continuum, which is treatment. Now, that's a very large umbrella. So today's discussion will likely be high level, but I'm looking forward to talking to you about the big picture items when it comes to what we use to treat lung cancer.
Well, I love to talk about lung cancer, so that's good.
Well, then I'm in great company. Before talking about the treatment considerations, let's just talk kind of, again, level set on the disease itself. Can you give us a big picture view of what are the common sort of types of lung cancer that we're commonly treating?
When we talk about lung cancer, we typically break it down into two types of cancer, non-small cell and small cell. So non-small cell is the most common type, makes up about 85% of all cases. This is the one where you typically will see about 20% of those cases in never smokers. And then small cell lung cancer makes up about 10 to 15% of cases now. It is on the decline because people are quitting smoking, and small cell is strongly associated with heavy cigarette smoking. And that is a more aggressive cancer that chemotherapy is really an emergency to get into these patients very quickly just due to the aggressiveness. There are some other subtypes such as carcinoid, atypical carcinoid tumors in the lungs. That's a lot less common, probably makes up less than 5% of cases of lung cancer. And some of these are hormonally driven and typically treated very differently.
So now let's talk a little bit about the stage at which we are seeing patients get diagnosed. Can you give us an overview of what those percentages look like in terms of stage at diagnosis?
Unfortunately, because lung cancer is pretty aggressive, we'll see lung cancer mostly in stage 4. So about 50 to 55% of all cases are not caught until they are already metastatic or stage 4. And then about another 25 to 30% of cases are caught in stage 3, which means they're locally advanced and often not resectable. But we do still treat that with curative intent with concurrent chemoradiation. And then only about 20% of cases, or 10 to 20% of cases, are found in the early stage, in that stage 1 and 2, where we can do surgical approaches.
Before we move into the treatment, talk just briefly about the diagnosis. So what are some of the diagnostic modalities used that typically, or what find the lung cancer? And then also, if you could, I know this is a very deep topic, but we know that biomarker testing is sort of a routine part of that initial pathologic diagnosis. So maybe you could highlight a few of the notable biomarkers that we see commonly associated with lung cancer.
When you talk about diagnostic modalities, there's generally two ways. One of them is a bronchoscopy. So that would be done by an interventional pulmonologist, and they do a bronchoscopy, and we now do something called an EBUS, which is endobronchial ultrasound along with the bronchoscopy. And that helps the pulmonologist be able to use a small ultrasound probe to be able to biopsy the lymph nodes particularly better when they're doing that. And that helps us stage the mediastinum. So we know, is this a stage 1, 2, 3? And it's easier to get, a good amount of tissue. So that's the bronchoscopy route. The other way we would do it is with a fine needle aspiration. And usually that's done by interventional radiology. And that would be sometimes, if it's a peripheral lung mass, we can stick a needle through the chest and biopsy it that way. If it's a metastatic site, then we can stick a needle in the metastatic site, especially if we want to determine if that's actually cancer or not, though PET scans usually tell us if it is. I like the bronch. We typically get more tissue with that. It does require anesthesia, though, because you're going down the throat and the air pipe. So that's a problem with that. With biopsying metastatic sites, sometimes we don't get enough tissue if we do FNA, especially with bone. We don't like to FNA bones as our primary diagnostic tool because then we can't perform molecular testing usually on it because of the way they have to decalcify the tumor. So those are primarily, now the other obvious thing is resection. If you have a brain met and you resect it, or if you have a lung mass and you just take them right to surgery and resect it, that will be, your surge path would also be a way to diagnose it. But we typically like to have a tissue diagnosis before we take them to surgery so we know what we're working with. Your question about biomarker testing. So yeah, this is something that we could really talk about for a very long time. We do like to get biomarker testing for non-small cell lung cancer, and particularly for those patients with non-squamous, which is adenocarcinoma, which is the most common type of lung cancer that you're going to see. And you can argue to test all the squames as well. The squamous patients are a lot less likely to have actionable biomarkers, but they can, particularly if you have someone who's a minimal smoker, young in age, things like that. Many places nowadays are just testing all of the squamous patients in addition to the non-squamous. So I think there's more to come on that, but it's really important to get that biomarker testing in the beginning so we know what we're treating. And that can be hard to do depending on the size of your specimen. So we do need a fairly good chunk of tissue. So usually with a bronchoscopy, they are able to get us a nice core biopsy of one of those lymph nodes or something like that. Bronchial brushings from cytology will not cut it usually. And then, like I said, if you're biopsying a metastatic site, you don't want to do bone because we're not going to be able to run molecular testing on that. So if you're doing like a fine needle aspiration, just make sure they know that a core would be great, a core biopsy, and the primary mass would be really great if we can get that site.
So now let's talk a little bit about the different types of treatment modalities that a patient with lung cancer is likely to receive. While we know most lung cancers will go on to systemic treatment, sometimes there are some that start with surgery. So can you talk a little bit about when surgery is appropriate for a lung cancer diagnosis, and then what are some of the typical surgeries that are performed for this?
Sure. So if we catch patients who are in stage 1, 2, and some stage 3, the gold standard is a surgical approach to cure that cancer. It's interesting because even small tumors, 1, 2, 3 centimeters, the definitive surgery for that is a lobectomy. And some people will say, well, why do you have to take out my entire huge right upper lobe if there's only a 2 centimeter marble sized mass in it? That is considered standard of care. And it's because of the chances that there's micrometastatic disease within the lobe, lymphangitic spread within the lobe. So that still is the standard to do an entire lobectomy. Now, there are times where we would do like a segmentectomy or a wedge resection in patients who, say, have really poor lung function, or maybe somebody who's had a prior lobectomy on the other side, so just doesn't have a lot of lung tissue left. But doing a wedge resection or even a segmentectomy is often considered incomplete surgery. And while you may get clean margins, we always take that into account if they didn't have a lobectomy. Now, how you do the lobectomy, I'm not a surgical MP, but what we typically are seeing now is robotic surgeries and video-assisted surgeries. There's something called a VAT, a video-assisted thoracoscopy. And this minimizes the huge incision. So, I think back, I've been doing this for 22 years. And, 20 years ago, the standard lobectomy was a huge incision that basically started in the front of your chest, went the whole way around the side and into and up your back. And then they use forceps to spread your ribs apart and get in there. It was rough. The recovery was rough. There was a lot of long-term pain management. And so now that they can do these video-assisted scopes where they can just make 2 smaller holes, you're still getting an incision and there's still going to be forceps with rib spreading that has to occur, but they're much smaller incisions. Patients are having less complications long-term. So I think that's good. I think the only other thing I'll say about surgery, as opposed to when we get into like chemotherapy and immunotherapies, is that there's pretty much data to show that when you're getting surgery, especially thoracic surgery for cancer, it's best to go to high volume centers where there are dedicated thoracic surgeons as opposed to general surgeons, because they're doing a lot of these procedures and they're specific to that site of the body. And I don't say that to minimize a community surgeon or anything like that, but surgery is something that's being performed by the hands of a person who does it, as opposed to like if we mix chemotherapy, it's the same vial of drug that someone else is going to mix. Like we don't mix it any special way. You know what I mean? But a surgeon is sort of like they are the chef essentially in a kitchen. They are doing this with their hands. And I would want someone who does that often and that procedure often there is data to show that there are better outcomes when you get surgery at a high volume center where they're doing a lot of these procedures. So it's just something to think about.
Now let's talk just a little bit about radiation. When in the continuum of the treatment, when is radiation often used and what makes a patient sort of appropriate or recommended for receiving radiation?
You can use radiation at really all stages, probably not usually with stage 1, but actually, honestly, you can use it in stage 1 if the patient is not a surgical candidate. And we can use stereotactic body radiation to do what we say like is a postage stamp radiation to a tumor. And, again, surgery is the gold standard, but if a patient cannot have surgery for some kind of reason, we'll do a stereotactic approach if we feel like there's just one mass that's relatively small. Same with stage 2. We could do concurrent chemoradiation for someone who's not a surgical candidate. The majority of radiation that you're going to see is for patients with stage 3 disease that's inoperable. And at my institution, a lot of stage 3 is inoperable. Now, neoadjuvant immunotherapy has changed that a little bit. But, if you have several big, bulky mediastinal lymph nodes that makes you a stage 3, surgery is probably not going to be a great option. So we give curative intent chemoradiation to these patients. And, they radiate the whole mediastinum as well as wherever the tumor is. And depending on the size of the lymph nodes and the tumor, it can be a pretty big field. So this is, again, something where I would consider going to a high volume center where the radiation oncologist specializes maybe in thoracic radiation and has a good feel for this because they're going to do the plan. They're going to figure out the dose and how to keep radiation off of the vital organs. There's a lot of vital organs in your chest, Jaime.
Right.
You don't want it hitting your heart. You want to minimize the esophagus, even though the esophagus is in the way and it's going to get hit. You want to minimize dose to the spinal cord. You want to minimize dose to the other lung. And that can be really hard when you're doing chest radiation. So this is something to take into account. In stage 4, most radiation is going to be for palliative intent. So maybe a painful bone met, something like that. The last thing I'll say is, there's sort of 2 main ways that we do radiation with either photons or protons. And photons is the regular way. And, we use IMRT approaches. And these are important for patients getting radiation to the chest because if you haven't noticed, you can't stop breathing. So your chest rises and falls, rises and falls. And this is something where an IMRT approach can be really helpful when they're simulating you because they are simulating your chest rising and falling. So the radiation has to follow that path because we're just not able to have patients hold their breath for a long enough time during radiation. And then protons is a different form of radiation that I think the goal of protons is to minimize toxicity, to have less of an exit dose. So this would be a radiation beam going into you, but stopping at where the tumor is, as opposed to going the whole way through your body. The idea here is to minimize radiation, get better effect on just the cancer tissue as opposed to healthy tissue. Big, expensive machine. We've had ours for a long time. I think there's good data. I think the data's not as strong as what we thought maybe it would be, as opposed to a regular linear accelerator. But we are using a lot of proton therapy at my institution. Again, particularly in patients with lung cancer, where you're radiating an area that there's a lot of vital organs in the way. So yeah, that's radiation in a nutshell.
I think you brought it up both with surgery and with radiation. Like these are skills that are taught and crafted and honed by the physicians or in radiation's case, the physicists, the dosimetrists. Like these are skills that they improve with over time. Just as nurses, when we learn to start an IV, like the first time where most of us are awful and it takes a lot of reps to get really good. And then you have that one nurse that you're like, when there's the hard one, that's the one you want. The patients know that. They come in and request that nurse. And so in the same way of these very specialized, very high risk types of interventions, finding a place where these physicians, these practitioners are doing them all the time just gives them that opportunity to improve that skill and really give patients the best chance at outcomes. You mentioned briefly about certainly when stage 4 disease is found, and that is often where we do find our patients being diagnosed at that stage. Sometimes there are certain modalities that are used then and used in a different way. So can you talk briefly about when lung cancer is diagnosed at stage 4, how does their treatment sort of options look different compared to when it's diagnosed at an earlier stage?
Generally, when patients are diagnosed at stage 4, that means the cancer is spread outside of the chest and it's no longer in a curable situation. Now, before we delve into that, I will say there is this idea of something that you may hear as an oncology nurse called oligoprogression. So oligoprogression would mean they have metastases, but only to one site. And sometimes we will be aggressive with that, particularly there's good data if the only site of progression is in the brain. We can do, like stereotactic radiation to the brain and then treat the chest, if it's only there, with concurrent chemoradiation as a more definitive approach. But outside of that, the majority of stage 4 lung cancer is going to be treated with systemic therapy. The idea being that we need to put something into the bloodstream that's going to get to every part of your body, because the cancer spread from the lung by either the lymphatic channels or the bloodstream. And those are the only really ways that it can spread like that. So we know that we need to get something into the bloodstream and thus the lymphatic system that will hit everything. And likely when there's one site of metastases, oftentimes there's probably another one that is seeded that we just don't see. So systemic therapy is the best option.
Well, that's a perfect segue then. Let's start talking a little bit more about those systemic treatments for lung cancers. So let's start with maybe the newest guy on the block, certainly the one that I think we see the most commercials for. Let's talk about immunotherapy. What immunotherapies are commonly used to treat lung cancer? And I know this is a big topic, so we can just hit the highlights of what are some of the notable drugs we're seeing and really how has this changed treating lung cancer?
I don't even know how new I would consider it anymore. I mean, I think we're a solid, well over 5 years. I mean, we're probably 10 years now into immunotherapy in lung cancer, which is awesome. And for me, clinical trials even before that. So it's not even necessarily that new anymore, but there are newer ways that we're using it. So I'll start with stage 4. We can use it in combination with chemotherapy or by itself. And there's a whole bunch of drugs that can be used here. There's pembrolizumab, there's atezolizumab, there is nivolumab with or without ipilimumab. There is durvalumab with tremelimumab. There's cemiplimab. That's the 7 drugs that I can think of off the top of my head. There's a lot of different options that we have, some of which can be used as a single agent. And, this is where we look at the start of looking at biomarker testing. So one of the easiest and quickest tests we can do is PD-L1 testing, an immunohistochemistry stain on your tumor cells. And that expression level can predict for how you may respond to immunotherapy. Now, even when you're negative, we still know that adding immunotherapy to chemotherapy is better than chemo alone. So we typically are going to treat the patients who are PD-L1 negative and PD-L1 low with a less than 50%. We're still going to typically give them chemotherapy plus immunotherapy. Now, whether that's a doublet immunotherapy approach, whether that's chemo with one of those other drugs as a single agent, there's several of them approved. They all have pretty similar data. Some have been around longer than others and have longer term data, but the toxicities are fairly similar across the board. So it's a matter of choosing what you're comfortable with, what you've used. There's a lot to be used in that space. I think the take home message there is that even if you're negative or low on the PD-L1 scale, adding immunotherapy to chemotherapy, there is still absolutely a survival benefit. Now, what if you're PD-L1 high? So that would mean a 50% or higher expression. So what do we do there? Well, these patients, we can give single agent immunotherapy, or I hate to even say the word single agent because you could use ipilimumab, nivolumab as well, which is a doublet immunotherapy. I'll say a chemotherapy-free regimen where you can, immunotherapy by itself, and data has shown this, is better than chemotherapy. So that's a nice look because we don't even have to give it chemotherapy and we can spare them those side effects. We can salvage it till later, till when we need it. So a lot of those patients, I'm typically going to use an immunotherapy only approach and see how they do. And a lot of them respond very well. And I will tell you, Jaime, there are definitely patients of mine who have been cured from just immunotherapy alone with stage 4 disease. And that is not something we really talked about 10 years ago. And it's not even that rare. So I would say, well, it's rare that happens, but it's definitely double digits for me. And I feel pretty confident saying this. These patients of mine that I'm talking about have been off of any treatment for well over 5 years with no evidence of disease. And these patients had several sites of metastases. So I think this just really speaks to this amazing modality of treatment of immunotherapy, making your own immune system attack the cancer. Now, patients being cured in stage 4, it's not going to be the norm. It's not even going to be 10%, but it's definitely more than a handful. So it's been really, really exciting for us to see immunotherapy take hold and really be the cornerstone of therapy now. And then I guess I'll keep going a little bit. It's now, we're using it in patients after concurrent chemoradiation in both small cell and non-small cell. The use of durvalumab, one of those immunotherapy drugs, has been shown in both non-small cell and small cell lung cancer to improve survival after the finishing of concurrent chemoradiation. So we're using it in that setting. And now we're using it in the neoadjuvant setting. And this is really where we've again really seen a really uptake in outcomes here. So this is combining immunotherapy with chemotherapy prior to sending a patient to surgery. In the past, when we had a patient with stage 2 or stage 3 lung cancer that we were going to take to surgery, we would just send them right to surgery. Don't fool around. Get that tumor out and then get them to adjuvant treatment. But the problem was they were recurring at pretty high numbers. Even stage 2, you had a greater than 50% chance of that cancer coming back and being metastatic. And stage 3, even higher than that. So they looked at, and chemo alone wasn't doing much for the outcomes, but the addition of chemo and immunotherapy for 3 to 4 cycles before surgery, we are seeing significant improvements in overall survival, complete responses on pathology once they resect it that we were not seeing with chemotherapy alone. And the idea here, Jaime, and I got to say this, initially I was like, well, then you're delaying surgery and getting it out. But if you think about it, why does cancer come back after you resect it? It comes back because somewhere those rogue cells got out of that original tumor in your lung and were circulating in the blood, and we didn't know. We couldn't see it. They're not big enough. And so the idea is like, rather than waiting for systemic treatment, boom, let's do it quick. Maybe that's mopping up or cleaning up some of these micrometastatic cells that are circulating, then take them to surgery to get it out. That's the idea behind this, is getting that systemic therapy on board quicker before you remove the tumor. And we're seeing some really great outcomes by that. So this is something that we're doing a lot now, is neoadjuvant preoperative chemoimmunotherapy and then getting them to surgery afterwards. So I think that's really one of the biggest immunotherapy advances that we've had in the past 2 years in lung cancer.
Just really amazing just hearing you talk through it and just thinking back. I think a lot of clinicians, even patients, still hear lung cancer and just we make that automatic assumption of like, oh, this is not going to end well. And certainly that is still true, unfortunately, for a large number of these cases. But as you've talked through, just the notion of like, you can't have a single brain met, but we can potentially just treat that and still have a good outcome. We can use immunotherapy either in different combinations at different times when we're seeing these changes still happen, these improvements in outcomes for patients with lung cancer. So it's really just exciting to hear you talk about how it's changed. It also makes me think of it, whether it's, in the movies or whatever, or even, family or friends saying like, oh, well, I had surgery and they got it all. Just always makes me cringe, on the inside, because we know that's likely not true. Sometimes it could be, but we know that surgery alone might not get it all. And that's, as you've talked about, doing either neoadjuvant or adjuvant treatments of just because we don't know if we got it all. And so just exciting to hear how immunotherapy is now part of that discussion of here's how we hope to get it all by using these things in combination. Well, since we're talking about it, you already brought up biomarkers. Let's move to targeted therapies. Talk a little bit about the role that we see targeted therapies playing in lung cancer treatment.
Yeah. And again, I won't bore you too long with this because this is a whole half-hour podcast in itself. But, I talked earlier, biomarker test. So when you get the biomarker test results back, and you should wait, you should try really hard to wait until you start treating someone, until you know what these are. There are a lot of them now in lung cancer, a lot. The more common ones are things like EGFR, where they should get an EGFR inhibitor. And there are several of them out there. And there's now bispecifics that can manage it. There are orals that can manage it, orals plus chemotherapy. So EGFR has a lot of treatment options. And typically, chemo alone and certainly immunotherapy don't work well. So you really want to get your EGFR-directed therapy. If you find that, and that's one of the most common ones we'll find. One of the other more common ones that we find is KRAS. And now KRAS is only actionable if you have the G12C in particular variant. And that is right now, the treatment for that's still in the second line setting. So the interesting thing about KRAS is they actually do respond pretty well to chemo and immunotherapy. They're one of the ones that actually does. And so if you have KRAS, we're still going to start likely with chemo and immunotherapy. But then in the second line setting, there is KRAS-directed therapies available. And then they get less common. ALK and ROS1 are other ones that chemoimmunotherapy does not typically work well, but their targeted therapies work very well. We are seeing median overall survivals for metastatic disease in the 5+ year range with our newer generation ALK inhibitors. These patients, it's not uncommon for them to live 5 to 10 years with metastatic disease, and even longer, some of my patients. this is really important that we find these if they're there. Now, I will say, with ALK and ROS1, they're almost exclusively in never smokers or minimal smokers or distant smokers. So for those two, for sure. And then you have a myriad of others. You have MET exon 14 skipping mutations. You have RET mutations. Those two are a little bit less common, but their targeted therapies work very well as opposed to chemoimmunotherapy. We have BRAF V600E, just like melanoma does. We have that in lung cancer. And those treatments that are targeted to BRAF can work well, though those patients with BRAF, they also can do okay with chemoimmunotherapy. So BRAF's a little bit different. And then the really uncommon ones like the NTRK, NRG1, I have yet to find either of those, Jaime, and all I do is lung cancer. So, these are really uncommon. They're fusion genes that are, less than 1%. But again, if you find one, the targeted therapies work very well for them. So it's just important we're looking for all of these and checking for all of these.
Absolutely. I think clearly lung cancer wins the prize for the most alphabet soup of targeted biomarkers that we can hopefully find and target, which is great for patients.
We're very proud of it.
As you started out, it's really important to not only make sure that these are all being tested for, but also helping the patients understand that it's worth the wait because it could drastically change what treatment they're started on and better match them with the one that has the best chance of working for them. And so I think that's a huge important point for us as nurses to not only understand ourselves, but to be able to discuss and sort of counsel our patients about, because it's a nerve-wracking time to wait when you want to just rush to whether it's surgery or treatment. So being able to kind of share that perspective is really important. Let's go back to the oldies but goodies. What are some of the common chemotherapy drugs that we are still seeing used in lung cancer treatment?
For those patients who don't have an actionable mutation, or for those patients who do not have high PD-L1, our backbone, whether it's with or without immunotherapy, is still going to be chemotherapy and platinum. So either carboplatin or cisplatin, typically in the metastatic setting, we'll give patients carboplatin because it's a little bit easier on them. In the curative intent setting, sometimes we'll try for cisplatin. It has just a hair of a survival advantage over carboplatin. But in the metastatic setting, we generally are going to use carboplatin-based regimens. Now, what you pair with carboplatin, we always use a doublet. So for the non-squamous patients, pemetrexed is the best drug. It's 10-minute infusion. You have to supplement with folic acid and B12 injections, but really well tolerated as long as they stay on their folic acid and B12. And really pretty easy drug to give along with carboplatin. Now, in the squamous patients, we're typically going to use a taxane, gemcitabine as our doublet drug with the platinum. Depending on patients' comorbid conditions, you can choose between that. And then I'll tell you, we don't have a whole lot of second line options. Docetaxel is approved in the second line. You can give the VEGF inhibitor, ramucirumab with that. Another VEGF inhibitor is bevacizumab, which is approved, not generally in the second line setting. You can use it in the first line setting, but we don't use it that much anymore because we have immunotherapy. But yeah, there's not a lot. Then in the second line setting with chemotherapy, you can use something you didn't use in the first line setting. So if they got pemetrexed, you can go to a taxane. But it really drops off after that frontline treatment when it comes to chemotherapy.
And then finally, maybe this is the newest guy on the block, antibody drug conjugates, relatively new for all of oncology treatment. Are there any of these types of drugs that are approved and used in lung cancer?
Yeah, so ADCs is definitely the newest on the block for lung cancer. We're trying to feel our way through this. So the only drug that's approved right now is trastuzumab deruxtecan. That's approved for patients with HER2 mutation positive lung cancer. And HER2 is one of the biomarkers actually I forgot to suggest when we talked about biomarkers, but HER2 mutation positive lung cancer as opposed to expression in breast cancer. And then technically now you can use trastuzumab deruxtecan for patients who have HER2 plus 3 IHC. And that's like a pan tumor approval, including lung cancer. So that would be an IHC test. That would be less common, but the HER2 mutations, they only occur in about 2% of patients with non-small cell lung cancer. But if they do, we can use this trastuzumab deruxtecan. Now, there's another drug that's probably going to get approved pretty soon called Dato-DXd, or I think it's datopotamab deruxtecan. And that's going to get approved in the EGFR space as well. But did not meet its primary endpoint in the overall lung cancer population as opposed to chemotherapy. So it's likely that that drug's going to see an approval in the EGFR space where it performed better. Outside of that, we don't have any other ADCs approved in non-small cell lung cancer. But I will make note that in small cell lung cancer, we do have a new drug class on the block, which is a bispecific T-cell engager. So for small cell lung cancer, there is a drug called tarlatamab that's a bispecific T-cell engager. And this is the first bispecific T-cell engager that's approved at all in any solid tumor. That was a liquid tumor thing. That drug's kind of making its mark there in the second line setting. And, it's got its toxicities that we have to watch out for, but, more to come on that.
How exciting. And not that we need to add one more thing, one more kind of therapy, but we do, because if it's going to be effective, it's going to help these patients, then it's worth making our decision making in terms of treatment. If it's more complex, but it's still better for the patient, we'll take it on. So clearly this is all very complicated, all these different treatment modalities and the timing of when they happen. It can be a lot for us as clinicians to kind of get our arms around, and certainly to be able to talk our patients through that. So how do you see nurses, what is their role in guiding our patients as they have to make some of these informed decisions about all these different treatment options?
Yeah, I think it's important for nurses to know that there's a lot of different options now for treatment. Probably one of the most important things is making sure patients are aware of what their biomarker status is, what their PD-L1 expression level is, and make sure those tests have been done, and then that they're basing the treatment. And, their oncologist is likely doing that, but it's good that patients understand that there's a myriad of options, and a lot of that depends on what we know about your cancer. And then that guides our treatments. So I think, just making sure that patients are aware of that, and that a lot of our treatments are doing a lot better than they used to in lung cancer. When I started doing lung cancer 22 years ago, it was just paclitaxel and carboplatin. That's all we had for patients, essentially. We didn't have immunotherapy. We didn't have ADCs. We didn't have targeted therapies. But now we have so many different things. It's just important for us to help our patients understand. And I think the other thing too for nurses is helping them understand the difference between why you would get surgery and why you would get IVs, whether it's immunotherapy or a systemic therapy with targeted therapies, even if they're oral. It needs to get to your whole body. I feel like I explain that to patients every day. We need to get this treatment to every part of your body through the bloodstream, because that's the way it's going to manage cancer that is spreading through the bloodstream.
Well, Beth, it was a big topic, but I think we did a great job of hitting all the highlights and really just giving an overall sort of bird's eye view of what the treatment for lung cancer looks like. And I really appreciate your time and your expertise again today. As we reach the end of our episode, we like to always run through this quick fire series of questions just to help summarize some of the things that we talked about. So to start that off, how do you think healthcare professionals, we should evaluate maybe our hidden or our implicit bias about lung cancer treatment?
Do not assume that your patient does not have a biomarker. Don't assume that based on race, gender, and smoking status. Test everyone, because everyone may have them.
What are some common misconceptions about lung cancer treatment?
That it doesn't work and that you're going to die very quickly. We have a really, like I just talked about, especially with immunotherapy and targeted therapies, we have a lot of great treatments that patients are living long-term now on treatment.
What's something about this topic that's not often discussed, but you wish people knew more about?
I really think I have to go back to biomarker testing. I know I talked about it a lot, but I just think that it's so important to know what your biomarkers are. And maybe you have been on lung cancer treatment for a long time, and just in the past 5 years, we've doubled the amount of biomarkers we know about. So maybe you need to go back and be tested again. Have you been tested for all of the biomarkers? Make sure you have been. Those targeted therapies can work so much better and be less toxic.
What additional training or education do you think oncology nurses need to stay current on this topic?
I think it's just so hard because, we hit all these different classes today of drugs. A lot of other disease sites, they have some targeted therapies, they have some immunotherapies. In lung cancer, we have it all. We have chemo, we have IO, we have targeted therapies, we have bispecific T-cell engagers now. We have other bispecific monoclonal antibodies. We have orals, IVs. We have really every drug class outside of CAR T. And I don't know, that could be even coming.
I was going to say, maybe we just wait for that one.
I know. I think it's just so important now that, particularly for lung cancer, you have to be well-versed on really all of these. It's hard, but ask questions. Just ask questions.
And then finally, what are some additional resources you would recommend maybe for patients or other providers who want to learn more?
Yeah, I think there's just so much on the web now. You can go to so many different places. ONS has a lot, so I think just going, especially if you don't have time to attend conferences in person, there's so many updates that you can get, even for free, and get your CEs online. So just looking for that.
Well, thank you again, Beth. It's just been a pleasure talking with you and learning more about lung cancer. I certainly learned a lot at this episode, and it's always a pleasure to talk with you. Do you have any final comments to share with our listeners today?
No, just thank you for giving lung cancer its time in the sun. I appreciate you dedicating this podcast to it. Thank you for having me.
Thank you. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.